And on behalf of Dental Protection, it is my pleasure to be presenting to you our quarterly series of webinar tonight. I would like to thank Dr. Goh, Dr. Ng, and the SDA team for being our co-organizer for this session tonight. I hope everyone is well, and I'm delighted to be connecting with you virtually. In tonight's webinar, we will be covering on wisdom, truth, and implants case studies. I would like to showcase our agenda to you tonight. It will be an exciting night where we will cover 5 case studies. This will be led by the DPL team, Dr. James Foster and Dr. Louis Eggleton. In each case study, we will be joined by Dr. Ng Fui Chin, the Vice President of the SDA, and Charles Lim, our DPL legal firm. Before we start the main program, I will be giving a short presentation on our DPL membership. My name is Julia, and I'm taking care of business development in Singapore. I work very closely with the SDA team. Today, DPL, we proudly support members in the United Kingdom, Ireland, South Africa, New Zealand, Australia, Hong Kong, Singapore, Malaysia, the Caribbean, and Bermuda. Sometimes the price of indemnity seems high. Unfortunately, this is because dentists are providing healthcare in an ever-increasing litigious society. An innocuous situation or clinical faux pas can lead to years for a dentist defending his or her actions in court and comes with it significant cost. So in DPL, our assets are owned by our members. Because we are owned by and accountable to members, we act in the interest of individual members and the interest of a membership as a whole. We are different to shareholder-owned companies whose primary purpose is to make money for other people. We don't answer to shareholders. There is no one to pay dividends to or to tell us to abandon our purpose because the profit isn't there. All our decisions are focused on doing what's best for membership. We take mutuality seriously because it's our commitment to you, not just today, but for as long as you need us. So in DPL, it gives you the protection that you need to practice with confidence in today's complex and uncertain healthcare environment. It is very important for you to identify who offers this protection for yourself and what protection you will need. You are responsible for the lion's share of the decision about the parameters that define how your risk, financial security, and reputation can be safeguarded. When it comes to potential litigation of medical or dental malpractice, it is unfortunately a case of when rather than if. DPL recognizes that dentists are likely to experience incidents during their career lifetime. As a dentist, you will need to ensure that your insurance or indemnity providers provide the following support or cover. So for DPL, how are we unique? Our in-house experts can assist with a wide range of legal and ethical problems that arise from their professional practice. This may include assistance with clinical negligence, claims, complaints, dental counsel inquiries, legal and ethical dilemmas, disciplinary procedures, inquests, and fatal accident inquiries. We also have an access to a dedicated expert legal team, which may include clinical negligence solicitors, dental legal consultants, and professional claims managers. You can request representation for coroner's inquests, disciplinary and regulatory proceedings, and criminal investigations related to your professional practice. Expert support, including preparing statements and responding to media on your behalf. At DPL, we can also actively campaign for regulatory and legal reforms that benefit members and the wider healthcare professions. You can request indemnity for clinical negligent claims and Good Samaritan Acts worldwide. So here we also provide a range of offerings that can benefit our dental malpractice cover, which includes private hospital and hospital groups, dental affinity groups, allied healthcare companies, dental corporates, dental schools, and training facilities. When choosing your provider, you will need to ask yourself, will I need peer support? So these insurance or indemnity provider that I seek, Do they have a Dentolegal team of fellow dentists that I can talk to confidentially? If the insurance provider is providing at such a cheap price, are their costs sustainable? Will they be in the market for the next 50 years in Singapore like DPL? If the insurance is so cheap, are there limits in their T&C? So too often for DPL, there has been misconstrued information about discretionary indemnity. So for us, our discretionary approach is to provide assistance. Isn't about saying no,
I don't know.
but it's about the flexibility to extend beyond the norm and ask how we can help. So the indemnity that we provide to individual doctors and dentists is based on the principle of discretion. This means that we have the flexibility to provide assistance when new issues arise in healthcare, which may not have been known when the insurance policy is taken up. With experienced dental legal consultants and specialist solicitors at the core of our team, we can use our judgment and insight to help our members, like yourself. With more choice in professional protection than ever before, I'm sure you know in Singapore, you will need an organization that goes further than anyone else to protect you and your interest. And we understand that you might have questions about your indemnity. Here, there are some common questions that we've been asked. Like, for instance, what is the flexibility of discretionary indemnity so important? So, when it comes to dental clinical negligence, it's a specialist area of expertise and it's very different to areas covered by traditional forms of insurance, such as car or household cover. It can be and often is in several years emerges. So in the medical and dental industry, it is continually changing and it's rarely straightforward. So new challenges always arise, some of which are inconceivable just a few years ago. So for us, when it comes to discretion, it means we can offer you the help in unusual circumstances where a new problem occurs, in which we use people and not contracts to make these decisions. So we have got a claims management team which are based in-house that work for you, which means that you benefit from the expertise and combined wisdom of your peers. So we've got a team of doctors and dentists and legal experts who know the healthcare system and your specific challenges. So we're different because we treat each case on its individual merit. And because we are a discretionary organization, our starting point has always been, how can we help? So another question that we always get is, why should I pay for membership when there's no formal guarantee of assistance? So our discretionary approach to providing assistance isn't about being able to say no. It's actually about having the flexibility to look at how we can help. So when we protect our members, so when you compare your products, you will see that you will note that for DPL, the occurrence-based cover is in respects to tort in dental negligent claims is based on a full compensation principle. So this means that members will be protected when a claimant who has suffered as a result of medical or dental negligence is entitled to be compensated as far as possible for all pecuniary losses. Claims made insurance, on the other hand, has got additional obligations around the reporting of adverse incidents. So for a dentist, you've dedicated your life to taking care of others. But in this new and uncertain time, it's never been more important to take care and protect yourself. So dental protection and medical protection, we have been offering comprehensive occurrence-based protection to individual and even corporate members across the world for many years. There are some important differences between occurrence-based that you have with DPL and the claims-made protection that you get from the other providers. In particular, around the reporting of incidents, indemnity provision upon retirement or ending membership, and how subscription prices are calculated. So in tonight's webinar, although I have seen quite a couple of familiar member names, we recognize that some of the attendees today are non-DPL members. If you would like to ask further questions or even have specific questions to compare your current indemnity and insurance coverage, please do get in touch with me. So if you wish to join DPL, I've got a QR code here. You can actually scan the QR code Alternatively, you can actually contact our partner, the Singapore Dental Association. So for further questions, you can actually go to our website. So please keep safe. But what I'll be doing now is, before we start the main event, I would like to pass my virtual mic to Dr. Goh, the Singapore Dental Association President. Dr. Goh, please.
Thank you. Greetings, especially to our members at the Singapore Dental Association. Thank you for joining us on the eve of the long weekend. I see that some of us are really raring to go. I do see that even on the Q&A, there are already questions and cases being posted, and to try to at least address some of the issues that have been posted during the segment later on. The reasons why we came up with this is because members had given us feedback that they would like to have some case discussions. So hopefully this will be the first of a series of case discussions to address some of the issues that the members face. Right. Today on the panel, we have with us from the dental protection side, Dr. James Foster, who is Head of Dental Services for Asia and Australasia. Dr. Foster qualified from the Newcastle Dental School in 1990 and was in general practice for 16 years, during which he held various roles with the Northern Deanery in Education and also worked as a clinical supervisor in prosthodontics at Newcastle Dental Hospital. He obtained a master's degree in medical law in 2005 and has further obtained his MF at GDP UK and a certificate in clinical education. In November 2019, he was awarded the Foundation Fellowship of the Faculty of Forensic and Legal Medicine of the Royal College of Physicians. Joining him, his DPL colleague is Dr. Louise, who is an international dental legal consultant for DPL and manages cases in UK, Asia, and South Africa. Louise completed her dental degree at Leeds University and gained experience as a general dental practitioner in both NHS and private practice for a number of years prior to moving to a role of senior dental officer within the NHS Foundation. Completing an LLM Masters in Medical Law and Ethics. Locally, we have Charles from Charles Lim LLC, who heads 2 teams of lawyers specialized and dedicated to medical legal defense work at Charles Lim LLC. With nearly 30 years of experience under his belt, Charles has been widely regarded in the medical legal industry for his experience and knowledge. In 2018, Charles was invited by the Law Society of Singapore to provide valued opinion and responses to legislative changes to the High Court and State Courts Protocol on Medical Legal Claims. Charles is an advocate and solicitor of the High Court in Singapore and a barrister at law of the Middle Temple. Charles is also a notary public and a commissioner of oaths accredited by the Singapore Academy of Law. Finally, a stranger to us, she's the Vice President of the Singapore Dental Association, an oral surgeon by training, and as well as in private practice. And I think she needs no further introduction. So without any further ado, I'd like to hand over this time to James to take us through the first case. James, please.
Thank you very much, Dr. Goh, and a good evening to everyone. I hope everyone is safe and well. Now, I'm just looking to share my screen. Let's see if that comes up in a second. Is that sharing there? We're good. Okay. So what dental legal cases can arise from wisdom tooth and implant surgery, and how can these risks be minimized and such cases managed when they occur? Well, I do hope you enjoy the session this evening. We've got some cases to go through, and we have my slides moved forward there. Okay, Dr. Goh? Just a thumbs up. Yep, super. Thank you. And I'll start just a quick overview of some broader matters. Just over the past 10 years, MPS has opened over 236,000 cases, including assistance with nearly 37,000 clinical negligence claims. These have been opened on behalf of medical dental members across the world, and such experience enables us to share our experiences to the benefit of the profession. And we always believe prevention is better than the cure. And from the case's experience, we can derive a knowledge and understanding of case management and what approaches are in the best interest of members. Hence, we've developed a proactive approach with the benefits of discretion being able to assist members at an early stage. Advice from a fellow professional and local legal assistance can provide reassurance and comfort to a member if they have a dental legal ethical question or concern and aren't sure what to do next. Early advice can also help prevent claims and complaints from escalation. Now we'll look quickly at the variety of cases that we see. Now, dental legal issues can arise from a huge number of issues. However, we tend to break them down into 7 case types. Advisory, well, dentists need often advice on dental legal matters such as retention of records, or they want guidance in managing difficult situations or indeed difficult patients. Reports, for example, a patient may have an accident and ask for dental records to demonstrate injury, such as for a car accident. Members often ask for an opinion or a chief expert witness report by the claimant's lawyers, and that can lead to some issues about disclosure, about what to say, and about the content of any report. And also we get reports, people saying, I've been asked to provide records for unhappy patients, and obviously the issues around that. Now, complaints can see routine clinical matters such as dissatisfaction with the denture through to a nerve injury, and some complaints may also include practice management issues. Often see other elements brought into a complaint, and it's important to establish the core elements and not the peripheral wrappings of a complaint, and address these core elements first. Reimbursements, is there a vulnerability for the individual clinician if the treatment was to be scrutinized by others? This may be by a claimant's experts or dental counsel appointed expert, and part of the initial assessment that Dr. Liu and myself might carry out is to request records and establish if there's a vulnerability or not. And often in dentistry, it's clear. If not, we will appoint experts ourselves. Now, if there is a concern with either the treatment or consent process, then it may be best to reduce the risk of escalation by funding the remedial and corrective treatment with another dentist specialist, and the indemnity organization us pays for that treatment, pre-arranged through the members. Now, regulatory, there's another substantial case, the dental council case. Everyone gets very concerned with the prospect of a challenge to their registration. Advice on the approach to take, draft submissions with panel, remediation as mitigation of sentencing, and assistance with panel representing at any hearings that may unfortunately arise. And a big one is claims. Everyone talks about being subject to a claim. Complaints may develop into claims, and dental council investigations which have adverse findings may also develop into a claim as the patient seeks financial compensation on top of reporting someone to the council. We use legal teams in country and with panel, and also with MPS, have clinical input from individuals such as myself, and we may also involve expert witnesses, as with the dental council cases. The claims take a long time to run through, and we'll see that in a moment. So the current dental legal hot topics, broadly speaking in Asia, the most significant ones include nerve damage, lingual inferior dental nerve following removal of wisdom teeth, and also through the placement of implants, but more in the former situation. We also see a lot of short-term orthodontic aligner cases and smile makeover issues, where the placement of elective cosmetic treatments or veneers has led to claims and complaints. But today we're focusing on the wisdom teeth and the implants. Now, we do see problems arising from wisdom tooth surgery, quite a few. The extraction of a wisdom tooth that results in paresthesia will be significant for that patient, but also for colleagues as well. We'll get up in the morning to do our best for patients, and it can be a very traumatic experience all round. Now, any subsequent investigation for a claim or a dental council matter will look at the pre-assessment process, the consent process, and the technique, etc., during the procedure. They'll also look at the competency of the clinician. Now, the area often found wanting is the consent process, and whether a referral for the specialist care and opinion was offered, and if not, then the patient may claim that they were denied the opportunity, therefore valid consent was not obtained. Now, the first case we're going to look at tonight saw an injury to the patient, and what I will do is present this first of all. So we have a patient attending complaining of bleeding when brushing around the wisdom tooth. I shall enlarge that for you again, and you can have a little look at the X-ray and radiograph, and just give you a few moments to have a little look through that. And if the patient was complaining of pain when brushing around the wisdom teeth, what might you have considered appropriate treatment yourself? Now, whilst you're thinking on that and subsequent questions will come in, I shall take you through events as they occurred. So what we had here was a single visit. All 4 wisdom teeth were extracted. The patient nurse, there was a forceps extraction technique used with no surgical approach, and unfortunately there was a fractured and displaced lingual plate on the lower left. These are the events in a time frame. Day 1, all 4 wisdom teeth extracted, patient not been seen before. Day 3, the patient requested a review appointment. Now, unfortunately, that appointment was not provided until day 7. And at that point, an in-house referral was made and the diagnosis was infection or inflammation. But by day 12, with a growing concern, the patient took themselves elsewhere. By day 20, the patient had complained to the dental council, although it took 2.5 years for the claim to follow. And often these delays are so the claimant's lawyers can await the outcome of the dental council investigation and the finding of the experts' reports, even though they are applying different parameters, breach and causation, as against meeting an ethical code of conduct. There's still some weight in those comments and experts' reports, and it's perhaps cheaper for a plaintiff expert to jump on those reports and use them for their own case. Now, in the dental council hearing, there were some facts established, and this is just to demonstrate the issues that and concerns that the council had. So patient attended. 15 minutes later, the nurse presented a form for the patient to sign, and that was a consent form. The defendant was absent through the consent process and no clinical record that the patient been informed of possible risk and complications, in particular 3.8. Now, the council agreed obviously about voluntary issues about consent and clear, simple, consistent language that the patient should understand. Now, in the present case, there was no difficulty about the discussions about the extraction discussed or the risks involved, and there was no documentation about the offer of a referral to a specialist. The allegations were failed to carry out adequate preoperative assessment, failed to properly advise the patient possible risks and complications, and failed to properly execute the removal. This was the outcome at the council. Competency focused. So case is a treatment case which heavily relied on clinical competency of the operating dentist. And competency, council expects knowledge and skill, meticulous attention to preoperative assessment, and the council was not satisfied with the competency of the defendant. So in order, their role is protecting the public, the dentist unfortunately had a 3-month suspension, which in a single-handed practice was fairly significant. The expert from the dental council, which I think is here because we're talking about the 3.8 roots close to the ID canal, suggests the path of withdrawal of the distal root quite different to that of the mesial. So there's criticism for not taking a surgical approach. Okay, so based on our documentation, a forceps extraction of the 3.8, which has curved roots on both roots being close to the ID nerve, was most likely the cause. And therefore, the expert said that the injury was due to poor technique. We mentioned that 2.5 give us an idea of what's involved with a claim of such a type of claim. There's paresthesia, there was neuropraxia, and that pain, that shooting, debilitating pain that comes with it, and that led to a psychological claim on top. The patient was depressed and struggled with this injury. There was loss of earning capacity, special damages, and medical expenses on top. And the patient at the time, I've converted this from a different country, but I've converted it to Singapore dollars. The total demand initially was 170,000 Singapore dollars. And as it turned out, there was 75,000 paid in damages with 52,000. You're looking at well over 120,000 for that one claim. So if I might, just having come across perhaps first to Fui Chin, for your views in terms of the technique that was taken there, and the fact that this young colleague felt that they were able to tackle the situation having just met the patient. And we talk about training and potential mentorship as being a way to help and avoid such scenarios.
Okay, sorry, Dr. Foster. Yeah, for this particular case, I think first and foremost, the dentist is the first time meeting the patient. You shouldn't jump into extraction immediately.
Yeah.
And second, you need to explain to the patient what you can, your analysis, your assessment of the X-ray. Obviously, for this particular case, the roots of the 3/8, as you can see, is very curved in unfavorable position because the two roots are curved against each other in the curvature, and the IDN nerve is crossing across the roots apices. Whether it's in contact or not, we won't know. You won't know until you have a 3-dimensional X-ray, do a CBCT. So basically, we have to analyze the OBG, and even remove the wisdom tooth. When you see that the root is in close proximity to the roots, to the IDN, then I would say that you should do a CBCT to view the roots so that you know where the nerve is. You also like to see whether how much tooth bone structure is buccal and lingual to the roots, because the roots is not really high up, it's quite low down to the nerve.
Yeah.
And that is where you can then anticipate the risk and the path of the method of how you're going to remove the tooth, whether you need to divide the tooth or whether you can do with just plain extraction.
Yeah.
Obviously, in this particular case, I think you should have divided the tooth so that the two sides, the two halves of the tooth can be removed in its curve of curvature, line of curvature there.
Thank you.
Right.
And in terms of the training, I myself, my experience upon graduation was that I had not embarked on a surgical extraction of a wisdom tooth like this, yet I had a degree and I was perfectly able to go out and do it. But thankfully, we had a structured approach where I could join a local clinic or surgery, and I could do some shadowing. There was some hands-on course and a mentoring. Would you agree that's a good pathway to follow? And is it open to younger colleagues in your environment?
Well, continuous training and learning is sine qua non of a healthcare profession. All of us will have to continue to upgrade ourselves. And you are fresh graduates, it is true that your experience is still at its primary stage. So therefore, you should attach yourself to some senior dentists to gain experience, to learn the technique, to learn how to manage the patient, and also to learn how to do proper diagnosis and how to detect and the risk and how to avoid it. So you attend courses or workshops of any clinical academic value that will help you. There's one method, but attaching to senior colleagues is a form of apprenticeship. Mentorship is a form of learning that is hallowed by time, and that has been proven over the years is a help. All the training of whether it's a specialist or a dentist, it helps them to gain the clinical experience. So in Singapore, if you are working in the government hospitals, you do have specialists and senior dentists there to guide you. And if you're working in the private sector, whether you're working in a group practice or in solo practice, and that is a bit of a difference. In a group practice, there is a good environment for you, because then you can learn from your seniors, you can share your knowledge with them, and they share their experience with you, and that is very good in helping one to grow. And if you are working in your own private practice, then I would suggest that look for some friendly senior dentists and look for them and ask them to help to mentor you.
Yeah.
Yes,
Thank you. And just a very quick point on that, if I may. Some people worry about being a mentor and do they need, and the same with the conditional supervisors saying, do I need some form of extra indemnity? No, it's the practice of dentistry. It's all part of what we do. And just one extra point is when these cases arise, often we see that the member has taken the decision to keep the patient under review and not to do any immediate referral for mapping, etc. Now, I think we share the same view about the need for a very prompt referral.
So I mean, building on that, for example, if somebody has indeed done a wisdom tooth removal, I mean, he has carried out the process correctly, and somehow paresthesia still occurs. I think one of the members have asked whether how do we resolve this? I mean, given that pre-assessment and the pre-assessment, the consent, and the procedures were properly done, but I mean, even in the best of us, sometimes these things do happen. So what is the?
But I think, and I'll bring Charles in a moment. But I think if you have a in terms of dental legal issues, if you have any case, any situation where the pre-assessments would stand up to scrutiny by experts, the consent process stands up to scrutiny, and the technique and everything is being done absolutely correct, and the material risk of injury to the nerve has arisen, because sometimes it is unavoidable, and that's the fact, it's shown to be unavoidable, unlike this case, then you can defend the case. Okay, so just because there's an injury doesn't mean there needs to be criticism or a claim that's successful. And perhaps if I just could ask Charles, you know, it often is, unfortunately, Charles, that maybe it's not the technique or the pre-assessment, but it's often the consent process that we see as the most common flaw in being able to defend cases. And Charles, furthermore, if you might just make comment as sort of the area in which the claims values in Singapore arise, because my understanding is sort of looking at just up to about 25,000 for lingual and maybe a bit higher for inferior dental nerve. Charles, would you agree with that?
Yes, the going rate, if I say so, is for a lingual nerve injury. For a nerve injury is between 25,000 to about 105,000. A lot hinges on the profession of, or the, well, what is the occupation of the patient. So it will be important during the consent process to carefully ascertain the occupation of the patient, because when there is a claim is always divided into three parts: a claim for damages for pain and suffering, a claim for loss of earnings, and a claim for cost of remedial specialist care to remedy the situation. I mean, remedy the injury that's incurred. The biggest head of claim normally is the loss of earnings, especially like the case where you have a chef who depend on taste for his livelihood. He was awarded $105,000 as damages for a nerve injury. As regards consent process, hindsight is always perfect eyesight, and we all, what we've seen in the cases that we come across in defending is that the most dentists do explain the risk and take consent. The difficulty is documenting the explanation and what was consented to by the patient. And you have an uphill task there if you don't document, because the SDC ethical code requires you to have proper documentation, and the test is always whether another dentist can take over your case without speaking to you. So if you feel that you say, but you do not document, you are really at the uphill task to explain why didn't you document what you say. And bear in mind that the patient is the lay person, the courts and even the counsel is always taken the position that as a professional, you should document, and they will tend to believe the patient more in the absence of documentation. So documentation is important. And as I say, so most dentists in Singapore are aware of the need to advise on risk and taking proper consent. It's the documentation that is lacking. And having said that, if the matter goes to a dental council proceedings, I should also say that it's pretty expensive, with a legal cost of between 40 to 50,000 for a day's hearing as a SDC. So when an incident like this occurs, DPL's instructions are always firstly try to assess the patient's complaint by sending the patient to refer the patient to a specialist for an objective assessment of the patient's complaint. And then we take it from there, because basically, as professionals, patients will complain, but at the end of the day, the patient's interests are most important when an incident occurs. We need to encourage the patient that, look, what is more important is that you get well and we know what's actually went wrong. That will then help you to maintain contact with the patient, to show the patient that your concern is his best welfare.
Thank you, Charles. I think we'll have one last question before we move on to the next case. There's a member who has asked that how, because I think James, you did mention that one of the things that this dentist failed to do was to offer a specialist referral. One of the members are asking whether it is important for every case, right, to be referred. For example, let's say if it's a simple mesoangular impaction and you have done like a series of successful cases that are documented, and suddenly one of these routine cases, the ones that you do has an unexpected complications that arise, would the failure to offer a specialist referral be held against you?
I think in any aspect of dentistry, whether it's endodontic treatment, some implants or prosthetic treatment, I think if you are looking at what is regarded as routine and well within the bounds of a GDP, then the requirement to make the offer of a referral becomes less significant. If there is anything out with the norm that is peers would say, well, hang on, that's getting towards the harder end of the spectrum, and depending on your own competency, we need to bear in mind that our own level of competency is fluid all the time. Those that have a lot of experience and can demonstrate that will maybe be further along that spectrum than others, and you need to be in a position to justify why you've taken that call not to refer. You don't have to say to every single patient, because you took that to its nth degree, you would say, right, okay, for a simple anterior crown, I'm going to have to refer you off to a prosthodontist because they might do it slightly differently. No, it's in the bounds of general practice. But if there is anything that is slightly implying more difficult, more risk, such as this case, then certainly that should be forwarded on, offered on.
Yeah. So
and if I may add, I think defensive dentistry is not sustainable. I think the question that the dentist should ask himself, like James said, can he justify a failure to refer? This is what the SDC will be looking at if it goes to a complaint. Can you explain why do you not refer?
Yeah.
That's all.
Yeah. All right. Thank you for the comments on the case. I think one of the questions that may be on members' mind is if, for example, some of these things have happened, how do you manage it, right? SDA actually has got a webinar, a SDA convention webinar, where Dr. Andrew Tay is going to speak on the webinar. So if you are interested to find out more, do sign up for our SDA convention webinar and hear a bit more about how to manage nerve injuries. Yeah, sorry, just a bit of advertisement for our SDA convention webinar.
Sure, absolutely.
Right, so James, maybe you'd like to bring us to the next case study.
I will, thank you. Okay, so here we have a situation that represents, unfortunately, a very bad day at the office. It was one that the outcome in the end wasn't too unfortunate, but the incident was. So what we have is the extraction of the wisdom teeth. There we see the issues. I'll let you just have a little look through that, look at the various sites. And we had an extraction that was carried out under, and this happened to be under GA. So we have 3-8 uneventful, 4-8 difficult, rotated. The 7 was chipped distally when elevation was carried out. Patient informed will repair after healing. Now 1-8 adverse displacement into the sinus ? So explained, and the further investigation, and this was just the written notes that I've put up there, but further investigation, more formal report basis. So during the procedure, the upper right impacted molar was displaced into the sinus. Lower impactions removed uneventfully. That was the thought. Complication discussed with the patient post-surgery, and patient husband has to come to the rooms post-op. On the post-op pan, displacement of tooth 1-8 in the sinus, but a possible mandibular crack was also noted. And I think it's an optimistic word of the use, possible, that we'll see in a moment. There were no displacement intraoral signs or signs of this during the surgery, and an immediate appointment was scheduled. So scan taken, and telephone and patient admitted, and the fracture was treated. And I just take note of this very bottom line: post-operative medication prescribed as recommended by MaxFax. Follow-up on phone calls during the weekend daily confirmed that the patient was doing fine. Now that's a significant point. So if we just come through to the pre-op again, and unfortunately the subsequent issues that arose, and quite significant, as you can see. And despite best intentions, nobody gets up in the morning to cause any difficulties. Very experienced practitioner, and unfortunately this is what occurred. Now, given the severity of the trauma for the patient, the need for further operations, you'd expect that this was perhaps a significant, difficult case that followed the member with potential of a claim in a dental council. However, it didn't at all. And I shall just explain in relation to that, and then we'll come back perhaps to the clinical aspects with Fu Chin in a second. This member immediately went on the patient's journey with them. A clear apology. Now, let me just first of all reiterate, in terms of an apology, some people think that's an admission of guilt. Now, clearly, an admission of guilt or admission of wrongdoing in this scenario is something that anyone should be happy to give, because there's been an injury, a significant injury. And people's reluctance maybe to apologize in lesser cases, particularly in this one, in lesser cases as well, often is a trigger. So just please be aware that to apologize to a patient for the outcome itself is not compromising your own situation. And there is a lot of research. It does not push you forward, does not drive patients to take further action. It does quite the converse. So an open apology, duty of candor with the patient's clarity, a regular telephone follow-up. You saw in the report, rang her over the weekend. There was a meeting held to discuss what had happened. Again, apology made. And a settlement was agreed without legal instruction by the patient. Now, in terms of patients, when they are damaged, compensation is about putting them back to where they were before and making an appropriate payment for damages. So the patient perfectly entitled to that. My role in looking after the fund is to make sure the fund is used appropriately. And by all means, when a patient has been damaged and there is a claim, that's great, absolutely fine. What we don't like to do is to pay out funds to claimants' lawyers when it's not necessary. In this situation, with assistance of panel locally, it was agreed a settlement was made. Now, at the end of the day, that avoids the need for litigation. And litigation itself is not something that patients look back on and reflect with a happy memory, because it's an adversarial, aggressive process where the plaintiff lawyer is pushing them to go in as hard as possible. The clinician certainly does not look back at a claim and enjoy the experience. Again, adversarial, aggressive, takes a long time. But at the end of this event, there's an apology. You stick with the patient. They shake hands at the end. It sits a lot better in the long run with both parties. Now, of course, there are some situations where a patient will go straight to a lawyer, But if you jump in and stick with them during the journey and look after the patient after the incident, you can really reduce that risk. Now, in terms of the clinical aspects, if we go back to the slide, Fuchin, we talked in the past about some techniques that would increase the risk of this occurring. There's been some elevation, there's been damage on that 7 as well. And in terms of the upper one, could we let's just explore how we might have seen this arise.
First, I must say I'm amazed by the dentist. There is this double tragedy here. The upper 8 has been displaced into the sinus, and the dentist still able to progress to take out the lower 8. And obviously there is a mandibular fracture at the angle of the right mandibular angle. Now, I think looking at this, my suspicion is that the dentist used a chisel to chisel the lingual plate to remove the wisdom tooth. He probably used a chisel for the upper jaw to remove the 8, and then use the same chisel for the lower. Now, chiseling technique of the lingual plate is a very fast technique to remove the wisdom tooth, but it's a very risky technique. Improper positioning of the chisel without doing proper stop cuts, improper angulation can cause the mandible to split and fracture, as I think this is what has happened. And I suspect there's a lot of force being used too, and that's why the distal surface of the lower right 7 has been chipped.
Yeah. And with a GA, slightly different technique is perhaps more adopted. But in terms of the upper tooth, that's something that could happen if we are, could be a little bit more foreseeable. But a careless day.
There is one sort of question, one general question on in hindsight, these things you said that perhaps could, more for the previous case, that such cases maybe could have been more properly assessed if we had a CBCT, right? And that may have avoided some of these injuries. So the question is, in your opinion, would you encourage people to take CBCTs? And would the lack of CBCT put you in a weaker position should a complication occur?
Would you like to go first, Fuchin?
Generally, the basic radiographic imaging that you need for a wisdom tooth is OPG. When do you do CBCT? Well, we don't do CBCT for every case of impacted wisdom tooth. There are certain situations where you need to do the CBCT is when the tooth is very big and buried in the mandible. And you can see even from the OPG, that is quite close to the lower border. And you need to see the size of the tooth and the amount of bone that surround the tooth, the buccal and lingual side, which you cannot see in the OPG. The other thing that's very important, if the tooth, the roots of it, seems to be in close proximity to the IDN, whether it crosses it, curve around it, or superimpose on it, and it's better to do a CBCT to know where you're doing. And the third indication is if the wisdom tooth has a huge pathology with it, like a cystic change or whatever changes in the ramus, then obviously you need to do a CBCT.
Thank you. I would, and just in line with that, I would suggest, the question says, would you be in a weaker position? Well, I think if you have an OPG or some radiographic technique and you haven't used that further diagnostic tool, you shouldn't be criticized if there's no indication that further diagnosis was required. So if the OPG indicated that it was in a safe position and a reasonable body of people, an expert could be found to support your decision not to investigate further, then that's absolutely fine. It's only if you don't take the further investigation when you should, because the anatomy demonstrated shows there's a potential risk. Would you agree, Fujin? Yeah.
Yes.
Thank you.
So it depends on whether from your first assessment, if CBCT is indicated. If the tooth is not that close to the nerve, and you can have taken it out with the proper technique, it may not have caused any complication, lead to any complication, then the CBCT is not really the way to save you. Because whether you take the CBCT or not, first you have to know the risk and the correct technique to take out the tooth.
Yeah. All right. In the interest of time, maybe we'd like to move on to the next case.
Dr. Liu.
Or is there any other further comments on this case?
Charles, if I might just ask Charles, if you are looking, obviously, a patient who has a mandible plated and a further surgery to take out the wisdom tooth, clearly, it is in the interest to have this sorted out directly with the patient rather than the claimant's lawyers' costs on top. You agree?
I fully agree, and I will also encourage you to quickly go to SDA, ask for mediation.
Yeah.
Because okay, I have to say that I'm not working for SDA, just to qualify. But then, in the cases that we send the SDA for mediation, 9 out of 10 has been very successfully mediated. The one that didn't succeed was because the patient was from China, and she somehow dropped out of the mediation process halfway. So I think SDA is quite recognized by patients as an independent body. And I mean, I don't know how the mediators do it, but then the 9 out of 10 cases were very successful. And once you refer to mediation, if they really cannot settle, then the issue is whether the patient will proceed to legal. And again, that's when we come in and try to, we'll take DPL's instruction on how to resolve the matter quickly.
Okay.
Your advice to members is that while we are going for mediation, is also to involve the DPL lawyers as well, so that they can sort of like track the case.
Well, not really. I think we will support the member from behind with DPL's input on the matter, on the dental aspect, and then so that then we already have a objective view as to how the mediation is likely to pan out in a sense, right? And what are the risks and pitfalls that we need to address. And then we leave it to the SDA mediation, because under the SDA mediation scheme, lawyers are not permitted, which is a good thing, I will agree.
Yeah.
So then the patient will not feel disadvantaged or feel that, the dentist or the lawyer to bully me. It's very fair. I mean, both are equal before the mediator.
And I think when there's financial payout recompense beyond for further treatment, it sort of falls across to us then, but at least the mediation can bring the two parties together to point and resolve and just bring that, put some oil onto the situation to calm down and look at a pragmatic way forward. Yeah.
Yes, I fully agree.
Yeah.
Because frankly, if any patient walks in the law firm and wants to instruct a lawyer, most lawyers will say, give me $5,000 upfront deposit first. Before even taking on the case or speaking to the patient. And my understanding is that if you want to talk to a lawyer for a dental case, the first hour, they will normally charge you about $500.
And then the issue is that they will grow. There's a growing number of cases that we see the psychiatric element being added to the damages, because they can find a report to say this person isn't happy, and it's very difficult to say otherwise. Okay, maybe Dr. Liu is there. Okay, yeah. So we've seen some significant cases which have arisen from the placement of implants. So problems such as perforating the ID canal, causing nerve damage, or incorrect placement of implant positioning, so the implant can't be utilized or restored. There can obviously be a variety of clinical approaches to a situation once the problems have arisen. So we're going to just have a look at the claim case here, where a patient experienced iatrogenic injury, paresthesia to the lip and chin following implant placement at 4/6 that we can see on the PA, and damage to the ID nerve. So we do see some colleagues leaving the implant in situ, so choosing to review the implant after a short period of time, rather than using a window of opportunity in the first kind of 30 hours or so to remove the implant and decompress the nerve. Removal of the implant is a significant step to consider, given the
potential benefits to the patient. And so I'm raising this in this scenario as it's significant. I'm sure we will go on to discuss this in a few moments regarding this aspect with Fu Chin here. So in this situation, the patient and the dentist discussed implants at the lower right region to help improve function, eating, etc. Dentist quickly went ahead with surgery. Reflecting back on the case, there was very little evidence in the records regarding preclinical assessment, consideration position of the anatomical structures, width of bone, etc. The 4/6 implant was placed. You can see on the X-ray here, it was this X-ray was actually taken a couple of weeks after the surgery. Sorry, just to make that clear. 5 days after the implant was placed, the patient came back complaining of numbness in the lip and chin. Dentist decided to review the patient again in 1 week. They still hadn't taken this X-ray. On the patient's return, they continued to experience the altered sensation. The X-ray was then taken and the dentist realized they'd placed the implant too deep. So arrangements were made to remove the implant. From the placement of the implant initially to removal, the period was around 3 weeks. So on this slide here, we can see just the image taken from the CBCT after the implant had been removed. A further 2 weeks later, the patient was then referred to MaxVac specialist as they continued to experience altered sensation. There's no change in their position. Patient was lip biting, drooling, experienced some hyperesthesia and had some issues with speaking as well. They felt that their speech had been affected. So the MaxVac specialist assessed the injury to be Sunderland grade 3 to 4. Patient considered further surgery to potentially investigate and repair the nerve. However, with regarding the situation last year with the pandemic, they just chose to pause that decision. The patient did pursue a claim as a litigant in person. They didn't wish to instruct their own legal representation, but they did request compensation for their injuries and for their experience. So the case was actually settled, the equivalent, it was around 31,000 Singapore dollars. So it's just to give you some idea of the costs involved, which I know we've touched upon with Charles there. The patient did consider surgery, like I say, however, there was some limited recovery throughout the year. So the final settlement agreement was based upon different elements of compensation, particularly involving the psychological aspect of the claim. So how the patient's been affected, such as their problems with speech for a short period, which did affect the patient socially. So within the settlement, it also includes potential lifelong effects of the nerve damage, consideration of potential medications they may need in the future, and estimated costs of surgery should they opt to go ahead with that in the future as well. So the breach in this case, where the treatment provided fell below the reasonable standard expected of a dentist, was the preclinical assessment notably and the consent process, along with the standard of treatment expected with the follow-up care. So things like no surgical stent was used, there was no immediate post-operative X-ray, and delayed referral to the specialist after surgery. So again, notably, there was no follow-up phone call, there was no courtesy call, just to see how the patient was doing, inquire how they are. It would have perhaps become apparent a little bit sooner the patient was experienced paresthesia following the surgery. And also the delay in having a post-op X-ray, it would have gone a long way, obviously, in realising that the poor implant positioning was a significant factor here, and taking action to remove this sooner rather than the delay of 4 weeks there. Causation in this aspect, so what has flowed from the poor treatment that was provided. So obviously, like I said, there's failure to adequately assess the area. It's led to incorrect implant placement, causing the nerve damage and the associated symptoms along with it, which the patient will have potentially for the rest of their lives there. So cases such as this, where there is a clear vulnerability, can be resolved promptly and amicably, where the patient doesn't necessarily want to seek legal representation, and obviously with ourselves and Charles, we can help support our members kind of knowing what to do in this kind of process. The patient can be dealt with directly, very quickly and easily, hopefully, to resolve situations like this, which is why they receive the appropriate recompense and for dentists to have indemnity in place. So if this does occur, obviously, like we say, immediately contact us to kind of assess the situation and advise you the best strategy moving forwards. In terms of consent, colleagues who are considering their vulnerability on this kinds of issue, it's often a little bit confused. So just simply providing a warning of risks such as nerve damage does not automatically remove the ability of the patient to challenge it if that risk has arisen due to negligent treatment and avoidable damage has occurred. So this is seen in this case where there's clearly the positioning and application of the implant was negligent with an adequate pre-op assessment and consent there, along with the delayed referral. So consent is a huge area. We do have webinars on this and material on our website, and you'd hopefully go and have a little look at, including workshops and managing adverse outcomes such as this. So reflecting on the situation, if I can maybe ask Fu Chin your views in regard to the potential removal of an implant once it's become apparent nerve damage has been caused. What are the best timeframes for this, and what are your thoughts on the significance of early referral to a specialist in cases like this?
Obviously, if you put the implant into the nerve, within 24 hours from here, I always tell my colleagues, the GP colleagues, please remove the implant. You have to decompress the damage onto the nerve. Now, the damage that occurs when you traumatize it is first degree is the trauma onto the nerve, direct trauma on the nerve will cause the nerve to undergo degeneration. That is the first. There's a secondary damage. If you leave it there, all right, the secondary cell-mediated injury can occur, and this happens in the usually first 7 days following the surgery. So once you remove the implant, you have to get all the analysis where the damage is, where the numbness is. Of course, you have to do all the mapping up. You have to try to put the patient on neurobion and some form of steroid, because the steroid does help to control this secondary damage to the nerve caused by the trauma, the blunt trauma to the nerve. And then send to your friendly specialist to deal with it. Don't keep the implant in the nerve and send the dentist to see your friendly specialist after a few days. So 24 hours, do it. And in Singapore, a lot of patients uses MediSafe. And one of the requirements is you have to do an immediate post-op X-ray. So that will tell you whether your implant is close to the nerve or is infringed onto the nerve. So that will give you an idea. And follow up with the patient. If you find the implant is very close to the nerve, follow up with the patient the next day. And you feel that, yes, the patient has numbness, please call the patient back immediately, take the implant out, decompress it, put them on the neurobion, and also to control the swelling and to reduce the secondary cellular mediated damage, put on steroids, some form of steroids. So you usually use dexamethasone, and then please refer to see the specialist as soon as you can, as soon as the patient can get over to see them.
Okay, excellent. So I know as well with Charles, we've obviously seen an increase in implant cases like this, and you'll obviously help guide our members with the patient in this scenario choosing to act as a litigant in person. Are we seeing more of this, or what kind of implant cases are we finding, and is it easier for the patient to act as a litigant in person, obviously trying to avoid them to instruct their own legal representation for each case?
I find the patients try to threaten first. They will first threaten that I'm going to see a lawyer and that I'm also going to complain to the SDC. And then that's always the first step, and we need to manage the expectations to say that look, we look into the matter and then we will come back to you on the matter. But most times DPL, by that, having had the time, and we have got DPL's input as to whether the member is vulnerable, we will then try to, if the member is vulnerable, we will move quickly to try to settle the matter. Because like James said, there's no point in dragging the matter. I think, to me, when I act for a member, and DPL's interest is that member gets on with his life and practice as soon as possible. So we try to resolve the matter if as soon as possible if there is a vulnerability identified by DPL.
Okay, excellent. Do we have any other questions on this?
We have questions from the floor. So in terms of, maybe Fui-Chin, you can just share quickly, in terms of pre-assessments, what are the general areas of pre-assessments that one would need in order to do before an implant placement?
So we'd look at pre-assessments. We'd expect the patient to be assessed holistically. So if the patient comes in specifically requesting, one particular implant, again, it's a case of looking at the patient as a whole. What's their perio status? What's their caries? Is it appropriate to provide that treatment? So once those issues have kind of been reviewed and taken care of, informed with the patient, alongside that with what the patient's coming in and asking for, and then it's honing in on those specific areas to say, okay, what kind of x-rays do I need? Do I need to see BCT, or is an OPG and a PA enough to be able to assess that? And then, are you looking at the anatomical structures, or is there going to be difficulty in that case? So it's assessing, again, your clinical ability versus if you'd need any kind of referral, excuse me, sorry. And then from that point, it then becomes kind of your clinical opinion and your treatment plan, and bringing the patient on board with it. So explaining it properly, explaining what the risks are, the advantages, disadvantages, along with the cost of the treatment plan. So the patient, even if they come in requesting an implant, for example, is there a different type of treatment that is also appropriate for that? Can they have a bridge or something else? So what is appropriate? Has the patient been provided all that kind of aspect of it? And then moving along with the patient as they're kind of agreeing, or kind of just pausing to give them time to consider it, whether they want to take a particular risk, whether they want to have that second opinion with a specialist clinician or not, and basically whether they want to move forwards. So it's just reflecting on all those different elements as you go forward in the case there.
Yeah, and I think I want to add to that, also check on the patient's medical history and also his habits, right? Whether the patient has a immunological problem, is he diabetic? Patients, is he a smoker? All these factors that influence the success rate of the implant. And I think you have to discuss the patient whether he is a suitable candidate for the implant therapy. In addition to all what Louise has just said, I think that is what you need to talk to the patient too. Yeah.
Yep. All right. Thank you for this. I think we do have another implant case. Maybe we'd like to move on to the next implant case.
Yes, we do, and quite timely the comments there about the periodontal status, because the case that we have now is indeed a case about the placement of implants for a patient who had just lost the teeth due to periodontal disease. The periodontal condition was not addressed, it wasn't stabilized, and this situation developed very rapidly. Interestingly, in the UK, we have firm, the Dental Law Partnership, which is two ex-dentists who now run a legal firm where they sue dentists, and I'm afraid they are fairly active. This is an area that they target in terms of the loss of teeth through periodontal disease, the non-management of periodontal treatments, periodontal cases, and now in this regard also the issues arising from implants failing in patients with untreated periodontal disease. I'm glad to say they're a unique company just in one country, and it doesn't affect other countries, but we do see a lot of these claims coming through in relation to periodontal disease. So we sort of have a double hit with those restoring patients at high risk and those who haven't treated the perio. It is an interesting concept here that if you put some implants into a patient and they fail, then what are we looking at? Obviously there's treatments being provided, it hasn't lasted long, and it's failed. Well, clearly there'll be huge disappointment from the patient, very expensive, perhaps not the most pleasant of experiences to have them done. But what we do see is claims arising from this, and it's not just about a refund of fees. And these are the allegations that were put to this case: a failure to diagnose periodontal disease in the first place, failure to tell a patient she was not suitable candidate for implants, and undertook the provision of the implants whilst the active periodontal disease was present, and failed to recognize significant periodontal condition in respect of proposed implant treatment. Now, in basic terms, someone might think, well, quite naturally, say, well, you paid for the implants, they failed, okay, there's the money back. But in fact, it goes beyond that. And the current estimate on this case is equivalent to 35,000 Singapore dollars. And the reason that these are so high is if we look at the allegations that are set forward in a letter of claim, these are the words used. So the avoidable provision, the accelerated loss, the avoidable explantation, and it goes through each of the elements. And then we see down towards the bottom there, our client has suffered psychologically experienced depression as a result of the dental problems, sore and tender gums, pain, suffering, and inconvenience of remedial treatment. So a patient having to go through a procedure, even if it's a reparative procedure, that they didn't have to, they shouldn't have done had it not been for the breach of duty, then there's a claim that can be had. So that was currently at 35,000, which is quite considerable. So Charles, perhaps if I come to Charles, claiming damages for having to undergo corrective procedures, it soon racks up, doesn't it? It's not just a matter of, well, it's failed, here's your money back. We're not talking failed dentures. It's just when we take the risk to put implants into a patient with periodontal disease and it's ill-advised, then these things can become quite considerable.
Yes, well, firstly, the patient will be claiming for the original fees paid to the dentist, and then they'll be claiming for the new fees that they will pay to the new dentist to rectify the situation. So it's double the cost, and that is also separate from what they will say that there's psychological issues and time taken off. So it is quite expensive. So do be very careful in your history taking of the patient's parameters, whether it's suitable for implants.
Yeah, thank you.
We actually had a case where there was a psychological issue, and this was not picked up until the patient attempted something very serious, and then the dentist became aware of it and referred the patient to the IMH for the matter.
One question to the panel is, we do note that quite a number of periodontal patients actually do require implants because of the loss of tooth due to periodontal disease, right? If we have counseled the patient and we've told them they are not suitable, but they said, they tell us that, they tell the dentist, I understand, but I'm willing to bear the risk of failed implant because I really need the implant to eat, right? Should the dentist then proceed with it, having the patient known the risk and accepting the risk, or should they reject?
I would think legally, I think the dentist should document all this very carefully in the case notes, what he explained to the patient, and also offer the patient a second opinion. This is precisely what happened in the recent case where the patient said that he wanted dental implants because more convenient, and then make the decision to go ahead 6 months later, and after that has psychological issues saying that, oh, I have pain here, I have pain there, and wanted the whole thing removed. So I would advise the dentist to get a second opinion for the patient in such situation to protect himself, that he told the patient that you're not suitable.
Uchin?
Well, the first principle is do not put implant in the patient with active periodontal disease. Right? So if a patient has periodontal disease, please send the patient to see the periodontist and have it treated. And until the periodontist tells you now he is stable, he no longer has periodontal disease, although he has bone loss. So if it gives you the green light to go ahead, you can tell the patient the problems you will face because now he has less bone. But you know that patient with periodontal disease has to make sure that he able to keep his oral health, dental health enclosed closely, and then he goes back to control his gum health with the periodontist on regular basis, because they are more prone to get periodontal disease later on. So you have to inform the patient of these problems before you even start planning and talking about his implant treatment. And obviously, you can send him to see another dentist for a second opinion. That would be very good, because if all the dentist tells him the same and he wants to still take the risk, then as what Charles says, document it, make sure the son have active disease, make sure that he's cleared of active periodontal infection and is stable before you go ahead.
If I might interject as well, I think there's a there is a risk here. If you have if you do any treatment in an environment that's less than ideal, would you be able to obtain an expert to write a supportive report in relation to the actions you've taken? Is it appropriate to have commenced treatment in that? And then people say, well, I've got a patient who's so keen, they're going to sign a disclaimer. They'll sign a waiver to say, I've heard what you've said, I just want you to proceed. Now, when that's there's two things in relation to that. When a patient's pushing, firstly, they can't sign away their right to challenge you later date. They can't sign away their right to complain. And secondly, if a patient is coming with an attitude of saying, I don't want to listen, I just want it done and I'll sign something, be very careful, because it's that exact type of patient who will come back to bite, with implants or not, in a few months' time. So be careful. That's the nature of that individual who's pushing you, irrespective of what you are giving your professional advice. Those are the ones that will perhaps cause difficulties, as Charles just has given a case example before.
Yes, I fully agree, James. The cases I've seen are the patients who are pushing the dentist to do something which the dentist advises against. And at the end of the day, if you end up before the dental council, I don't think it's defensible, because one of the limbs of professional misconduct is a departure from the standards. If the patient clearly is not suitable and you still proceed despite all the clinical indications, then you really have to justify why you departed from the standard of giving implants to a patient who shouldn't have implants.
And it does bring into view the issue about consent that often confuses some colleagues, is that if a patient is requesting something and you get them to sign a consent form, when something fails, the consent isn't a protection for you that your treatment has failed. It's a very different element. Thank you.
One question maybe arises, if a patient has periodontal disease and has been controlled, can he have implant?
So if a patient has
controlled, stable periodontal health after suffering from periodontal disease previously, he's now under control, and the periodontist say his gingiva is all healthy, he has been stable for last 6 months, there's no problem, then can we go ahead to put implants in the patient?
Well, if that environment, find an expert to say that's a perfectly suitable situation, and then the danger is obviously if there's a relapse of the periodontal condition and that follows, and in that situation you want to be really, really careful about your message to the patient, the information you provide the patient, your records to indicate that the patient was fully aware of what was required of them, and journey that they were entering onto to have implants, and the need for them to be lifelong maintenance of the implants. And the fact, the issue here is the disease is theirs, not yours. You know, they are the ones that need to maintain the issue, and it's setting it out clearly such that if in 2 or 3 years' time the patient was to come back at you and challenge you and say, well, these implants have failed, then you can demonstrate to the patient and others, if required, that the patient was fully aware of what was required and the onus was upon them, not you. Are there any more questions on there, Dr. Go?
I think we are good for this. I think there was one question, but it probably would be addressed in the next last case study that we have for tonight. Really about whether our canine, upper canine implant being malpositioned, whether the surgeon will be considered negligent, or is it just poor intraoperative judgment?
Okay.
So what is the difference between a poor standard and versus a being negligent? Yeah, maybe you'd like to take us through the last case before.
Oh, last slide, and then we'll come back to that. Yeah.
Yeah.
Okay. Thanks, Lou.
Okay, so the next discussion is related to a regulatory case which involved 2 main clinicians, and it just really demonstrates the conflict that can occur when one clinician places an implant and another clinician restores it. So just a little bit of background to the case. During the case, we did discover that the patient already had a social acquaintance with the GDP, so they were already in kind of a friendship group. The GDP, who I'll refer to as Dr. R, provided routine treatment previously to the patient. The patient was then experiencing an abscess at the 4-5 post-crown. So Dr. R attempted to extract the tooth and ended in a root fracture, which you can see on the PA in the corner there. Dr. R referred the patient to a specialist maxfax to remove the retained root and assess the patient for implants in that area. So the maxfax specialist, who I'm going to refer to as Dr. I, provided 2 implants at 4-5, 4-6 position. Dr. I only ended up placing the implants and didn't restore them, as afterwards the patient wished to pause treatment due to financial constraints. So the patient did heal well. The implants were in situ for around a year, at which time they wanted to return back to Dr. I to restore them. At this point, Dr. I was taking a break from clinical practice, actually. So the patient was reviewed by a different maxfax specialist surgeon, just in order to assess the 4-5, 4-6 to ensure they were adequately integrated and fit for restoration, as they had obviously been placed some time prior to that. So on the following slide here, apologies, I know it's slightly blurry. It's really just to demonstrate the bone levels of the 4-5, 4-6 implants. They were still good following year of having no restoration. So the second maxfax surgeon assessed it, found both implants presented with good integration. The surrounding tissues were healthy, nothing of note, no pocketing or bleeding. There was just a very, very slight angular bone loss consistent with the implants being unloaded for the extended duration. So the patient went back to Dr. R to have the implants restored. Dr. R said, yep, I can restore these for you. Placed 2 implants at the 4-5, 4-6 crowns. Another year went by and the patient needed to go back to the maxfax specialist just for a different situation, an assessment of a wisdom tooth removal. Whilst they were there, the patient said, actually, I'm still having symptoms at the 4-5, 4-6 crowns. Can you just have a look? So the maxfax surgeon reviewed that area, which we can see on the next OPG here. So further examination of this area, the maxfax surgeon said that both crowns had erythema now, and there's bleeding on probing, especially around the 4-6. So you can see significant cratering bone loss in this area. It's a little bit worse distally. I think it was around 8 millimeters. Mesially, there was a 5 millimeter lost. The specialist advised removal of the 4-6 implant and to either remake the crown at 4-5 or to consider having another implant placement instead of the 4-7 and to restore it with a bridge. So the degree of bone loss at 4-6 to remake both the crowns to try to make the area more self-cleansing on an already significantly compromised implant was inadvisable. So to salvage the 4-6 implant would require bone grafting, which can often have unpredictable outcomes, and the patient was very concerned about the cost of this still. So the patient was led to believe by Dr. R, the clinician who provided the 2 crowns, the fault was down to the failure of the 4/6 implant. So as there was already a social acquaintance between the two of them, the patient was perhaps more willing to blame the clinician. They preferred the least. In this case, it's Dr. R, and made a complaint to the Dental Council regarding the treatment and implants. There was nothing of concern in the complaint regarding Dr. R within it. So Dr. I has found themselves with a regulatory investigation, having provided 2 sound implants prior to the restoration of them, and was really being held accountable by the patient for the failure of the 4/6 implant particularly. So having reviewed all the clinical evidence and specialist reports for this case, Dental Protection was able to demonstrate failure of the 4/6 implant was brought about by peri-implantitis, build-up of plaque, food debris, in relation to a poorly controlled crown, especially around the distal aspect between the 4/6 and the 4/7. So the 4/7 has obviously been root treated here, but there's not been an appropriate crown restoration placed on that. So including within this, Dr. R's notes also showed repeated attendances by the patient throughout the year complaining of food packing, and also suggestion to the laboratory to try and improve the contour of the crown. And Dr. R had also made adjustments themselves into proximally to try and adjust the contours as well, trying to improve them. So Dental Protection assisted in providing a submission to the Dental Council that there was no merit in the allegations, and the breakdown of bone could be traced back to Dr. R's failure to fit the correctly contoured crowns. So due to the space available and lack of crown at 4/7, Dr. R had effectively placed too large a crown on 4/6, which created a shelf extending distally, creating the area for food trapping and plaque, etc., to occur. So it was resolved that the explanation provided by Dr. I was accepted in relation to the alleged unprofessional conduct, and it was deemed Dr. I acted ethically and professionally following all necessary protocol in fitting both the implants. So really the case demonstrates the importance of establishing what clinicians specifically provided what treatment, and also establishing the clinical condition of the patient prior to treatment, during treatment, and after that phase of treatment has been provided. So for this instance, we were able to robustly defend Dr. I's position, where you would perhaps initially just look at the OPG and immediately think failure is due to the implant provision. So rather than the restoration, which is obviously not always the case. So for this, I'll probably, if I ask Futin again, so regarding peri-implantitis and problems with implants, do you see a lot of this, and kind of what can we do clinically to try and avoid this?
Yeah, in the society, when you have lots of implant placed over the years, you definitely see quite a number of this occurring. Yes, I think the important thing is that before you start putting the implants in the patients, you have to go through all the analysis and make sure that the implant is positioned correctly and restored properly. And very important is to advise the patient that they need to have regular maintenance. Now, a lot of patients, after they have a nice implant placed, they think that that's the end. They do not need to see the dentist anymore until they get into trouble. So they may come back to you after 7, 8, or 10 years, and then you see a lot of better implantitis, and you ask the patient, we have been contacting you, asking you to come back for regular checkup, cleaning, and maintenance. You didn't come back. Did you go to see any other dentist to keep your oral hygiene clean, to check on the implants? And the answer is that they say, oh, I pay a lot of money for the implant. So after paying, I got the implant, it should last me whole life. So this is something which we need to educate the patient, that you don't just have the implant and then that's the end of the story. Implants is a start of a whole life maintenance, a whole life commitment.
Absolutely. And with Charles, obviously this, we managed to kind of demonstrate Dr. I's kind of role in this, and actually he wasn't to blame. So the case was kind of resolved quickly with the Dental Council. Obviously, if we don't have that kind of evidence in some cases, they can extend much longer with the Dental Council.
Yes, so which is why we always say, always tell the dentist that we really need to contact us early so that we can get the evidence for you and get the expert report out, and then take a position on the matter and how to defend the matter.
Yeah, so I think one of the things that was discussed was very interesting. I think whereby if let's say the patients do not follow up as they were recommended to, is there some form of contributory negligence on the part of the patient if let's say there is a failure that happened? For example, in this case, if let's say he was advised by the dentist who followed up on the crowns to come in at least once every 6 months, let's say, and she decided to come in only once a year, right? And this happens. How would the courts or how would the dental council rule on such a case?
Okay. The answer is that the dentist, as Dr. FSC, where my call say so, you should tell the patient that having implant isn't the end of the story. It's actually the beginning of the story. You need to have proper care of your implants. You need to see a dentist regularly to care for the implant. So all this must be documented, that you advise the patient that he needs regular checkup and the implant needs to be looked after. If you have that documentation, then I won't even talk about contributory negligence. I think the patient's claim would fail in the first place. And you go to the dental council, you can show that the patient was told about all this and documented, and the patient failed to come back despite repeated reminders, then the dentist would quite likely be exonerated from any allegations of professional misconduct. The interesting question is, patients will then come back and say, but you have a duty to remind me even though I don't turn up. So then the question is, what is the dentist's duty to keep calling a patient to come back for a checkup? The answer there is to document or send letters to the patient to request the patient to return for a checkup. So that it's in the case notes. The patient cannot say you didn't call me or you didn't remind me. Then it is really the patient's duty to also look after himself or herself and to have regular checkups. You have a complete defense then.
If I might come in and say, so there's also a difference between an implant and crown restoration, which is clinically excellent. There's nothing wrong with it compared to an implant that has been restored incorrectly. So in this case, especially regarding the 4-6 implant, the contours of it and the interproximal spaces weren't correct, which has very much contributed to the breakdown of the bone and the problem with the implant. So that's kind of one aspect of it. The other aspect is if you've placed an implant, you've got appropriate contouring of the crown, you've got good self-cleansing interproximal areas. You've given the patient that advice saying your oral hygiene, you need to maintain it. We advise you to come for a review, like Charles says, invite them or send out an appointment for regular recall every 6 months or whatever you might deem appropriate. If that patient is then choosing to ignore it, or if the patient has very poor oral hygiene, or there are other factors that the patient isn't doing that you have been advised, and then in that circumstance, obviously, the patient has that contribution to the breakdown of their oral hygiene and potential risk to the implant from that aspect of it, as opposed to whether there's something clinically wrong with the implant or crown there.
Yeah. All right. I think we are running short of time. I mean, just some closing comments. I think some members have concerns. I think there are some questions surrounding whether we contest every case, even though the dentist has done their due diligence. If let's say the settlement amounts, for example, they're asking is very much less compared to let's say the cost of doing a full litigation, do we sometimes settle even though the dentist has done their due diligence? For example, let's say if the patient is claiming for $3,000 to refund the cost of, let's say, $1,000 for the treatment, and do we usually close such cases?
I didn't quite catch what you said there, Dr. Go. Forgive me, it's my age, my hearing. I didn't quite catch.
Yep. So I think one of the members have observed, or rather in his observation, he feels that DPL has not been contesting cases, even though dentists may have done their due diligence, meaning that the dentist may not be at fault.
Right.
Right. Has it got to do with the claims being a smaller amounts and the cost of challenging it being
No, we would only settle a claim with the members' consent. This is if all of these issues stand up to scrutiny, then we can defend the case. If the opinion from panel, from counsel, from experts is that the matter could be defended, then we will defend it, as long as the member wishes us to do so. The early resolution, the resolving matters in the first stages, is based upon the presence of a vulnerability or a potential vulnerability if the matter escalated to the dental council. So you may see a situation where something clearly has been wrong. There may be another situation where the item of treatment itself has not been wrong, but the actions of the practitioner or the actions around that would draw significant criticism from the dental council. And you'll say, look, let's just get rid of this, because if this goes to the council, they're going to hammer you for X, Y, and Z, not A, B, and C. So we might resolve it in that. But if any member was concerned that they'd had a case that had been settled when it shouldn't have done, please speak to your case manager. Speak to the case handler and ask for further clarification, because we would never wish for a member to consider that the case had been settled on a commercial basis alone.
I can add to that my instruction from DPL is always to seek the member's consent to a settlement. We have never settled without a member's consent.
Yeah. So I think we would like to assure members that if, for example, any of you feel that the settlement has been purely on a commercial basis, you may contact the Dental Association, or you may contact your case managers with DPL, and we'll follow up just to make sure that you are being properly represented.
Yeah, there will be correspondence with the dental legal advisor or the case manager's details on there, and please just write to them if you have a concern. And the same with all situations. Any questions, please let us know.
Yeah, no, do let us know. Yeah. So so perhaps I'll just give a short summary. I think it has been very fruitful, and even for myself, I have taken back quite a number of learnings as well. I mean, for the first case, we talked a bit about the importance of having pre-assessments, consent, the procedures done correctly, and the demonstration of competency as well. And I think we talked a bit about whether what's appropriate referral. Do we refer all cases, or how do we demonstrate a failure to refer appropriately, depending on the kind of the skills, the amount of skills, your experience as well in dealing with such cases, and if it's brought towards before a council, would they deem your previous experience relevant or appropriate in order to take on the case that is currently being considered. Of course, in case 2, we talked about how the apology was not really apology of the outcome does not necessarily increase our litigation risk. In fact, many studies interestingly have shown that sincere apology for the outcomes and journey with the patient has been shown to actually reduce the risk of litigation to members, right? And I think also it's really about if damage has been done to the patient, to actually contact DPL and get a proper appropriate settlement with the client or with the patients early on, so that you can kind of shake hands and things can be settled amicably. So if really damage has been done, then it is right that we should settle early age, wait for things to escalate to points where lawyers or litigation is involved.
If I might just interject there, Dr. Goa, forgive me, but please contact us before you come into an agreement to settlement figure with the patient. Contact us, because it can't be left for members just to negotiate a settlement using the fund's money. They need to be in touch with us first.
Yeah, I think in all cases, I think the key message is really to contact early, even before the case has escalated. So it doesn't mean that only when you receive a letter from the dental council, then you start contacting. In fact, early on, if you think that there's a risk, you should contact a DPL, who will guide you along with the case settlement. Then we talked a bit about implants as well, and some of the managing complications even for members, rather than refer and wait. If there are nerve injuries and implants, we should quickly remove the implants, put them on steroids, as well as neurobion in order to try to reduce the complications and do it and refer it quickly to an oral surgeon, right? We also talked a bit about some of the pre-assessments that need to be done, looking at medical history, dental habits, whether there's presence of perial, caries, and having appropriate x-rays, looking at anatomical structures, and basically really looking at the case itself and what are the risks, what are the success rates, what are the risk factors, and then counseling appropriately. And most importantly, also discussing the different options that the patient has aside from implants. Of course, I think the last two cases were really talking about failure of we came on to the failure of diagnosis and really starting to whether we should commence treatments in a less than ideal condition, even if the patient is pressing on it and has claims to know the risk. I think we still, as Charles had pointed out, we should not deviate from the standards. And this does not, there is no way in which we can actually consent to sign away their right to complaint. So I think one of the important lessons to members is that no matter how much you are under pressure from the patients, if it is not the standard, we should either prefer a referral or a second opinion in order to cover ourselves, right? We should follow the standards and not deviate the standards because of pressure put on by us from the patients, right? Because we have responsibility to adhere to the standards that we have been taught, right? And I think there's also the idea of when we provide treatment, sometimes we may not remember to tell them what are the necessary steps following the treatment. For example, regular reviews, what happens if you don't come in for regular reviews, how often you need to come in for regular reviews, what are their duties in order to ensure success of the implants, for example, proper oral hygiene, and what happens if they do not maintain their own hygiene. So I think these are the things that importantly we need to document in our notes. That's also, I should also start to also look and review my own notes as well, and to in order to reduce the risk to kind of strengthen in these areas. Right. So I would like to really thank the panelists who has taken time to really be with us and to share their experience and knowledge. I'd like to thank Dental Protection for really organizing this series of events, and Charles as well for joining us tonight. And for the questions that we are not able to answer, we do hope to be able to try to address them either through a summary or sorts, or you can contact us directly if it is something that you are concerned about. If it is something that you're currently facing, please feel free to reach out to us. We'll be very happy to work with you or provide you with some of the answers. Right. So, if that's any other last comments from any of the panelists.
If I might just make one very quick comment, seeing some of the questions coming through, would DPL defend this, or why can a patient complain if you do this? In the environment, you cannot stop a patient making a complaint or making a claim or making a dental council complaint. It's the process of making sure that there's a fair process and that we defend your integrity and your reputation. The patient drives whether the complaint occurs or not. It's how well we can defend it once it's got there. So you can't stop a patient complaining, because the systems and processes are in there in society for people to make complaints and make challenges. And would we defend, or what's our view on this? We look at the overall picture. You get expert reports where appropriate. Of course, it's about protecting the individual. We're not certainly not a concept of not anti-patient. We're pro-dentist.
Yeah. All right. So with that, I wish all a very happy long weekend for those in Singapore, and we hope to see you at the next edition, and we do hope that you also give us your comments on how we can further improve this lecture series so that it becomes beneficial for all those who attend. And for those who have signed up for our SDA convention, we look forward to seeing you at our hybrid events or our webinar. Right? So otherwise, thank you, and good night, everyone.
Thank you.
Good night.
Good night.
Night.